Don't be shy, panelists. Let's go. Come on, people. All right. So we are looking for. Thank you, Dr. Link. All right. I see them coming up. If we could have the slide deck, that would be great. So. Yes, I definitely will as soon as we get to the. Good morning, everyone, and thank you so much for staying to the end. We have a great panel. As you can clearly see, I'm not Sai Babu, who also was very regretful that he couldn't make it here. Fun fact, we both have a daughter named Karina and like Pearl Jam, which I noticed last night at his AOS induction. Okay. See you get these going. So we are going to have a really interactive case panel. So I'm super excited. If you made it to the end, I would love you to give your opinion. So we'll sort of go over how the format is going to be. But we're going to talk about cases, clinical curveballs, complications, and tough calls. So let me introduce our panel. We have Dr. Hamid Djalilian, who's coming to us from Irvine, California. We have Dr. Michael Link, who gave us a wonderful lecture yesterday, Dr. Neil Patel from the University of Utah, and a very, very special thank you to Dr. Shawn Stevens, who is stepping in at the last minute to round out what I know is going to be a great panel. So a special thank you to you, Shawn. Thanks. Okay, great. So we have each of us some financial disclosures of various companies, et cetera. I'll leave that up for just a second, but none of these, particularly pertain to the panel. So this is supposed to illustrate some difficult decision making. We're putting up our complications. We're putting up our cases that are interesting. So let's all have a really nice discussion about this. I am very grateful Sai put together these slides for the most part, and we all gave him cases that he requested. So let's make this a really thoughtful and helpful discussion, and a special thanks to the panel for showing their cases. All right, let's jump right in. I will say from the prior slide, we're going to start out in the middle ear. We're going to make our way to the skull base, so Dr. Link won't be on the hot seat until a few minutes in, but I promise everyone will get a chance. The other thing I was thinking, since we're here at the end, please jump up to the mic if there is a case in particular that you'd like to see. We have about 10 cases we're going to get through, so we're going to just jump up and get started. But there's not going to be any particular audience response, so I'm really looking forward to the panelists' comments and anyone from the audience. So let's start with this one. 54-year-old female with this audiogram, suspected otosclerosis. You had a chance to look at that. Did have a CT scan, nothing special. So here we have a video. If you don't like endoscopic surgery, you can at least appreciate, see those little red blood cells on the, that's a really nice one to see. Okay, so we're looking right here at the area of the oval window, down fracture of the stapes superstructure. This is a measuring stick. The oval window looked narrow. We went ahead and did some drilling there on the cochlear promontory side of the oval window. This is an endoscopic case. I do a lot of endoscopic stapes surgery. And after this drilling, I don't know if you could see that there, but I see some pulsatile liquid. Don't have a great view of it right at this moment. But nice thing about endoscopic surgery is we can sometimes, certainly with the microscope as well, but perhaps with endoscopic surgery can get a little view here, and perhaps we're going to get a sense that we now have a hole there, a hole through which some fluid came out. So, panelists, Shawn, I just gave you a long thank you, so I'm going to have you pay me back on that with your comment. What would you do? What's the plan here? Going to abort? Should we freak out? Should we abort, get some fascia? I don't know. What are your thoughts?
I think the first thing I would do would be to freak out and then take a deep breath.
Yes, thank you.
Yeah, you don't see that very often. So yeah, I think it's probably not a bad idea at that point to prepare to try to cover it with some tissue. I think I would probably turn to the tragus, usually make a small incision. You can very rapidly harvest some perichondrium there. You could go behind the ear and get some fascia too, but then you may not have prepped the patient that way.
Right.
And then also, if the patient is awake, it's probably more likely that the tragus is already blocked. So there's a couple options there. And then the other thing is just opening into the cochlea. We do that all the time at the foot plate. So that will probably hold itself for a little bit. They're not going to immediately go deaf right there, as long as you're not suctioning on that or, probing it any deeper.
Thank you. Thanks for that comment. That's great. So maybe Neil, if you would you do the same, and would you continue, or let's say would you cover it and then go ahead with the regular stapedotomy, finish the case, or what are your thoughts?
Yeah, I couldn't tell, but are you in through the foot plate at the same time, or just into the cochlea?
No, it was just drilling on the cochlear side of that.
Yeah.
So it's yeah.
Yeah. A couple of things, like Shawn said, having some tissue around. I trained with Colin, of course, and we'd always just get tissue at the beginning of the case, and so I always have a small graft sitting there in case of a partial stapedectomy unintentionally, or you have a big opening or something like that. And so having that around ahead of time is better than the risk of blood going into the cochlea or fluid coming out. So I always just do that. Through a tiny post-auricular stab incision. But I'd cover it and leave it and then come back. If I were already into the vestibule,
Yeah.
then I'd probably just put the prosthesis in and use that to kind of help anchor that tissue in place. It'd probably be helpful.
Yeah.
But I wouldn't risk, having to do another 20 minutes of the operation potentially after that cochlea is open.
Yeah. Well, that's great. Thanks for those opinions. Yeah, that I covered it with some tissue. I used to always get tissue at the beginning. Then our institution did a RCT on whether you need the tissue or not, and our partners and I decided we didn't. So of course, this was the immediate next case. I'm trying to evolve with the evidence. There you go. So whatever. But I did decide to just abort. I was afraid that if I did get a sensory neural hearing loss in that case, but then proceeded, I wouldn't know, was it because of the cochleostomy or was it because of, so I stopped. Then I actually went to the other ear. I was just trying to kick the can down the road and did the other ear, got that better, and then eventually went back and it turned out well. Okay. We're going to do one other middle ear case here. This is a 62-year-old female. She had progressive mixed hearing loss. CT scan was pretty poor quality, but didn't have any obvious things. I didn't repeat it. That will be pertinent, perhaps. Okay, so went in. This is what I expected. Conductive hearing loss. So first thing, of course, is endoscopic view, right ear. Palpating the ossicles. Well, that seems not good. Okay, not too much movement here. So I've got a rock-hard malleus, I've got a non-moving incus, and a nicely mobile stapes. So definitely not what I expected necessarily going in. Obviously, plenty of etiologies here. The CT scan ahead of time did not have an obvious, malleus touching didn't have an obvious incus bar, nothing going on there. How would you handle that? Dr. Djalilian?
I usually use like maybe a 1 millimeter diamond burr and just kind of drill, or if I can curette, whatever I can curette, and then I'll reach whatever bone can't curette, and I'll just start drilling until I can find where exactly the adhesion is. And then I'll usually try to separate it with the laser there as best as could be done. Sometimes the bone's very thick and you just have to drill actually a little bit. And sometimes I use a 0.5 millimeter burr. And then I'll put silastic in between, and then I close up.
That's really helpful. Anybody else have any comments? Regrettably, could not get to that. I curetted it. Just there was no room anterior to that malleus. I looked around as much as I could. I just could not tell what. I couldn't get it loosened. Well, perhaps I could have, but perhaps someone could have, but I couldn't. Yes, Shawn.
So in these ones, I really haven't had a lot of luck trying to manipulate the ossicular chain up in that maleo-incudo region. Like if that's fused, I find that no matter what I do, the outcomes just aren't good. So usually what I'll do, and it looked like it in that video, the tympanic membrane had been removed, but a lot of times the malleus, the manubrium is medialized a little bit. So the tympanic membrane is actually in pretty close proximity to that incudostapedial joint. So what I'll do is I'll actually just remove and separate that IS joint. I'll actually truncate off sort of that lenticular process of the incus just so it's out of the way. And then a lot of times, like some of these like little Frisbee prostheses will sit on there, and if you rebuild cartilage, it gives enough vertical height to get back to the tympanic membrane. And then sometimes, like especially if the whole membrane has been removed, you can actually truncate that malleus, and that mobile piece of cartilage actually does a pretty good job. So I tend to get a little bit better outcomes with that than I do with trying to mess around with the first two ossicles.
All right, great. Yeah, I think I did some version of that with a just actually getting a porp onto the what was ultimately the mobile stapes, and I just couldn't even get that malleus loosened up enough to be included in the OCR, but came okay. All right, let's moving right along here. So this is a 17-year-old child that presents with right conductive hearing loss, no history of chronic otitis media or tubes, really no previous treatment, no issues in school, but came and of course concerned parents who want the hearing to improve. We see the right ear there on the audiogram as the one affected. So we're going to go through some of these cases, and I believe, Dr. Djalilian, this is your case, so hopefully we can get some insight from the treating surgeon. So how many on the panel here are getting CT scans for the evaluation of congenital hearing loss, maybe particularly, or for conductive hearing loss in this case? CT scans? How about the audience? Most people get a CT in this case? Okay, fair enough. Got it. And how about routinely obtaining acoustic reflex testing? Dr. Djalilian, do you routinely get it?
I generally do. Are there times that it's going to slip past me? Definitely, yes.
Fair enough. That's true for sure. We're going to get into a pretty intense facial monitoring and the use of facial nerve monitoring in a couple of the other cases. So maybe we'll save this portion of the discussion for next. Dr. Djalilian, would you go through some of the CT scans for us here?
Sure. This is, of course, the axial cuts here. So the first thing that sort of struck me that at the upper left image, the facial nerve looks a little strange at the genu there, at the geniculate, and then it sort of has a little bit of a weird course through the middle ear, and then and we look in the lower right panel there, you can see the foot plate, and it looks like the facial nerve is kind of running in that zone, maybe a little bit lower than it usually would.
And we have the coronal here.
And then on coronal, you see the facial nerve, but it looks like there is enough space that one could go sort of under to kind of reach the foot plate. The foot plate is narrow, in the lower left one, and you can see that there is appears to be a stapes there in the right upper scan, and the facial nerve appears to be it's low, of course, but it's not like significantly hissing on that image. But in the next one, it is the left lower one.
Yeah. So you're planning to go in for surgery. You routinely use facial nerve monitoring in these cases? Yeah.
Yeah.
How about a show of hands? How many, in this particular case, how many people are using facial nerve monitoring? Okay. I'm seeing the vast majority, maybe not every single hand, but certainly a vast majority, and that would make sense. So let's see some intraoperative. Maybe you can take us through some of these cases. I agree the CAT scan was, especially maybe the retrospective view, more informative.
Oh yeah, exactly. I mean, it's the retrospective view is always a lot more accurate.
Right.
So we sort of, as we entered, the chorda is sort of in the upper left. We'll start in the upper left and just kind of go down. And I had one that was labeled, but I guess you didn't get those images. Anyways, so you can see that upper left, what we see is actually the incus there, and the chorda is actually quite low, kind of compared to where you would expect the chorda to be. And then the next one, we can see that there is like what looks to be, with that rosy needle, I'm retracting the regular chorda, what appears to go under the malleus, and then there looks to be like a second chorda that was a little bit more inferiorly coming off and goes directly to the facial nerve there. And then you can see the tensor tendon, and of course the incus is on the left there. You can see the facial nerve is sitting low and sort of runs right below where the normal lenticular process would be. And the sort of next image on the upper right just shows that what I call it, the accessory chorda, was going right into the nerve. And the lower left kind of shows similar findings. And then I was just trying to, that right lower one, I was trying to show that it goes directly into the nerve. The image didn't come out really well. And I think I have questions on the next one. Yeah.
Yes. So maybe let's throw it out to our panel. Don't worry, Dr. Link, your time is coming. Not quite yet, but so I'm going to pester my other really generous panelists. Dr. Patel, what do you think?
Yeah, I think the same sort of applies, like your narrow niche question of trying to remove some cochlear promontory to get a little more space for a prosthesis. You can get a narrower, if you do the eclipse piston type prosthesis, you can get a narrow one. And I would just work a little superior to that. It looks like there's a little dark spot where there might be an oval window there. And I would, confirm with the scan that there's not a horizontal canal, that's thin right there, or something like that, or dysplastic. But, and try to go a little bit north of that instead of going toward the facial. And I've had a few cases of congenital foot plate fixation where the facial goes underneath the stapes. That's for any of the trainees. Congenital foot plate fixation should be antennae up for facial nerve anomaly.
Dr. Stevens, anything to add to that one?
No, not much. I think that was well said. I would probably give this one a go as well and try to go superior. Anytime you see that nice little dark window that's like a target, throw your dart.
Yeah, definitely going in for anyone with a congenital conductive hearing loss. We're sort of all, we all have our radar up for something. Dr. Djalilian, what happened?
Well, I guess maybe we should have had this panel before I did the case, but I actually didn't go for it. I thought that window was too small. So you see sort of a little dark dot. I don't know if you can point to it with something, but sort of above the facial nerve. And I was just maybe, I just thought, I don't want to get a facial paralysis from either the heat of the drill or something. And I just didn't think it was worthwhile, considering you could get some kind of bone conduction device and get good results. And definitely below the facial nerve, the incus wouldn't have reached, would have to do potentially a malleus stapes, and the angle would be very weird, going almost to the umbo region. So I actually elected to not do that because I was worried that you get retraction and then that would really penetrate the prosthesis.
I mean, this panel is turning out great. I agree. I probably would have done it as well. So we're there's a lot there. Lots of different ways to manage the same thing and with your eyes on it at the same time, something that looks like a dot here in a kid. And I think we all teach our trainees certainly, to be on the conservative side for especially a lot of these cases. All right, we're going to now move sort of right into more intense discussion of facial nerve and maybe some facial nerve monitoring. This is a really easy exostosis. And obviously, this gentleman, shockingly, having some recurrent blockage and infections. Okay, so who gets, just a show of hands, who gets imaging for exostosis surgery? Yeah, I think low-hanging fruit there for sure. We talked a little bit about facial nerve monitoring, but we're going to get into that a little more complicated. So this is a question for the panel. If you have a case and no facial nerve monitoring is available or not functioning, is that a reason to stop the case? Let's just go down the line there. Dr. Patel, what do you think?
Yeah, I wouldn't do it without it.
Yeah.
I think uniquely, actually, exostosis, not that I've had this happen, but I've heard of people who've had it happen or had a referral from somebody who did an exostosis operation and got a facial paralysis. It's actually not trivial because you have to work so much on the inferior aspect of the external auditory canal. I think Rob Jackler talks about that a lot. So I wouldn't do it. I think it's become the standard of care, and we're a training institution as well. And so I need that.
Yeah. We'll come to you, Dr. Djalilian, for sure. Shawn, you going to proceed?
I might actually be in the minority on this one. So I think the imaging really is helpful. Because one of the things we're looking for is it really just an exostosis? Like there might be some other things that could be underlying those big ugly humps.
Yeah.
As long as it is just bony growths down there, and you can usually see the facial nerve so well, I actually don't usually use facial nerve monitoring on these. I'm also the one by myself. I don't have any residents, so I figure if I screw something up, it's on me. And I guess so far, so good. You know, we've been maybe lucky, but we haven't really necessarily needed it. The other thing is I always try to use suction irrigation. I actually try to do these transcanal whenever I can. And usually with the smallest instruments, I can actually get a little irrigation in there because what I'm most worried about isn't drilling into the nerve so much as I am overheating it.
Yeah.
Because I think you're going to get some thermal spread if you're just going straight on bone dry.
So Dr. Djalilian, why don't you take us through this case?
Yeah, so this was actually a malpractice case that I looked at a while back. But anyways, this was the surgeon proceeded. There was a monitor, but it was not functioning. I personally would proceed. I also go transcanal, but I use the microosteotomes. And I've written papers on how to do it safely. So you can, our sort of goal is always go anterior, find the TM, and then you can proceed. So you never get lost trying to first take out the posterior one, which is actually what everybody wants to go for first. I only take enough of the posterior one off so that I can get to the anterior one, so I can first see the TM in a 100% case. And then we work from there and figure out sort of where everything should be. So I would have proceeded, but that's not necessarily the right answer.
So it sounds like, did they have a complete facial when they were referred?
So this patient, well, we can proceed now, and we can
Sure.
see what happened, basically. So this is actually a post-op CT scan, and you can see that there is sort of a blood or something in the middle ear. The sort of the best image sort of is the middle row. Basically, they went for the posterior one, and they went a little bit too far posteriorly, which is sort of usually the problem.
Right.
And so I sort of teach my residents is turn the patient away from you. So you want to be aiming anteriorly, even when you're taking the posterior one out, because the tendency is when we're sitting patients supine and we're looking, we're going to aim posteriorly, especially in a posterior exostosis. You don't need to go that far posteriorly. And if this was done with osteotomes as well, and they just been basically straight to the facial nerve, unfortunately.
Okay, yeah, here's, these are actually Stenver images, or these aren't true coronal?
These are sagittal, these are
Yeah.
sagittal images,
Okay.
You can see basically that the facial nerve, in that, there is basically a bony sort of chip that's going to goes across on the upper left. Yeah, right there, that there is basically that's pushing onto the facial nerve.
Okay, so you went for decompression there.
So actually the decompression was done elsewhere, I should say. And they found that the facial nerve was intact, but it was ecchymotic. So then the question is, well, what would you do at this point?
Great question. Panelists?
I'd decompress it, but I probably wouldn't try to instrument it much more if I was 100% sure that it was intact. But it sounds like that was the case, but I'd be skeptical and have a low threshold to really explore 100% of it as much as you could, of course, with the limitation of where the ossicles are in the inner ear. But
Yeah.
yeah.
I thought one of the key things in this case was doesn't recover for 3 months, then sees a plastic surgeon. So just to do Dr. Hadlock some justice from her earlier comments, I think that's a really helpful thing for us to keep in mind. Certainly no reason the patient needs to wait for 3 months to be sent for facial plastics. And then ultimately looks like it got involved with the facial plastic surgeon, who then proceeded to do some recon. Well, I want to make sure we get on to our skull-based cases, because I don't want Dr. Link's involvement to be so limited. So we're going to just keep moving right along here, and we'll talk about that a little bit later. So this, let's get to the skull base. 51-year-old with a unilateral vestibular schwannoma and a non-MRI compatible pacemaker. Poor hearing on that side. You can see the images here that we have. Progressive growth of this tumor. Patient had one previous episode of facial paralysis on that side. Preoperative facial nerve function was normal. Recommended a trans lab. Would anyone else do any other particular testing? We noted the MRI issues, but anything else? It's okay if the answer is no. Anything? Okay, great. All right. Neurotologist proceeds with doing the trans lab, our core procedure, as previously noted. And then actually, maybe Dr. Djalilian, you could take us through this as well.
Sure,
So
yeah.
some nuances here.
Yeah, this was a very complicated case, and some people here may know about it because this was a malpractice case also. Basically the trans lab was completed. The neurologist left the hospital to go to actually another hospital to do another case. The neurosurgeon sat down, was able to stimulate the facial nerve laterally in the IC, but could not stimulate the facial nerve at the brainstem or anywhere basically around the tumor. And I think there may be next slide. Just. Mm-hmm. So this is the questions that I
Yeah. So this is, I think, how some of that we can at least start some of the discussion here. And so, we're just going to start out with a really easy one there, Dr. Link, a master educator, as previously noted. I'm wondering if you could just give some general comments. What kind of communication are you looking for from the neurotologist before what's the handoff like? What kind of, just start anywhere. Feel free to start anywhere.
Yeah. We're really lucky that we only work at one hospital, so it's never an issue. Usually, Driscoll finishes the drilling, gets on a plane, and goes skiing somewhere else. But in all seriousness, throughout our careers, it's very much a team approach. So it just has never been an issue where. Obviously, we have some other rooms going and so on, but there's been a lot of cases, and particularly when we were starting, it was very, very helpful that often both of us are sitting there at the microscope. So he's giving me advice on my part of the operation, and I'm giving input, probably not helpful input on his part of the case, and so on.
Dr. Stevens or Patel, are there some things you always do before you sort of hand off, like maybe use a stimulator, show the neurosurgeon where it is? Are there some sort of traditional things that help formalize, especially maybe for when you're starting out to make a relationship?
Mm-hmm. Yeah, we have a protocol for this in the sense that we always want to try to hand off and have that next surgeon be as ready as they can go. We call it pointing out the landmines. Every once in a while, you might also have a dural venous injury with that mysterious piece of gel foam that nobody's quite sure what to do with. But really what we're trying to do is we'll give them a pre-call, usually about 20, 30 minutes in advance of when we're actually going to be done, to just give them some time to prepare. A lot of times the other doc, both the ENT and the neurosurgeon, may be in a second room, or they may be in meetings or who knows what. So it just gives them a little bit of time to kind of say, okay, let's get mentally into the game here. And then the other thing is when they do come, I try to never break scrub until I've pointed out the exact location of the facial nerve. I'll actually stimulate it so that they can see where it stimulates on the monitors. We'll point out sort of where the end of our tumor dissection sort of finished off and where they should begin. And especially if there's any kind of weird or atypical anatomy, we always try to kind of point that out.
Yeah, a couple of thoughts. I love my neurosurgical partners, but they have varying levels of experience. Mm-hmm. And when I'm with one of the junior people, I don't leave really for the majority of it. Maybe I'll step out while they're debulking with the Sonopet or something like that. The other thing is, this is going to reveal my training background and bias, is that, you know, for a translab, especially for a large tumor, you don't see the facial nerve at the brainstem at the beginning of the operation. So it's great that you can stimulate in the internal auditory canal, but that's the easiest place to find the facial nerve, and it's the least helpful for the rest of the operation. So it takes a while before, especially the junior people, to get to the facial at the brainstem. And so if you're not there for that, we've had some situations where they get lost. When I'm with Bill Caldwell, I can go and have a lunch in Park City, you know, and come back if I needed to. But that's a major consideration of mine, and so I wait around for a while.
Yeah. That's very helpful, and I think, you know, reflects sort of not just stage of training of you, but also of the team member. Dr. Djalilian, so I think Dr. Patel just commented on that exact thing. So, you know, what do you do if the facial nerve is not stimulating proximally, but does distally? And, you know, certainly that sometimes we aren't even at the brainstem at that point. Did you want to make any other comments here on what you do for the facial nerve monitor, specifically in this case?
Yeah, and this case happened to have a monitoring team. So they sort of checked everything, and everything was working because they could stimulate distally. It just wasn't stimulating proximally. And then the sort of question was, well, what to do at this point? And the sort of the preoperative discussion had been, the patient said, if there's any issues with my facial nerve, you know, if there's something stuck to the nerve, then I want you to leave that tumor be. And of course, there was a disagreement later on what exactly that meant and whether that meant the whole tumor or just a small part of the tumor. But so the neurosurgeon then decided to proceed with the dissection, leaving a pretty wide and sort of thick tumor on the nerve, but debulking the vast majority of the mass. And the patient unfortunately woke up with a grade 6. And really, the surgeons did everything they could to sort of really be super nice, but regardless, the patient, of course, still sued both surgeons.
Quick comment just before we move to the next slide. Are there, you know, when you dictate or when anyone on the panel is doing some dictations for these cases, do you sort of routinely have templates? Are you chatting with your neurosurgery colleagues how you're going to dictate this sort of at the end of the case? You know, not every case is as beautiful as some of those really nice videos we were seeing yesterday.
I mean, I have a template, but if a case is complicated, I generally don't have residents dictate for me because I just don't. They can sometimes do it very late, and then the details are all kind of mishmashed with other cases. So I do everything myself, but I do mostly template. But if it's a case complicated, I will actually sit and just type the whole thing out because I don't want anything that's in there that by mistake from a template got added in. And of course, if somebody's looking into it, they can see every part of it that was a template and every part that was typed in. So, you know, if you're going to do it, might as well do it. And it's best to do it same day. Don't sit and dictate like 5 days later because it's going to be very obvious you're waiting to see what happened before you dictate it, and you might change how you do it. So.
Maybe just add a question as well for the other panelists, for the audience. Maybe a show of hands is, at this point in the case where, say, the neurotologist did not leave, and you know that you have that going on, you discuss with your neurosurgeon, do you break for a second and actually leave the OR and go tell that family? We've seen this a couple times actually at Barrow. Thankfully, I haven't been involved in these, but where a surgeon actually left the OR, and this had happened, and then the neurosurgeons aren't quite sure what to make of that. So I'm just like walking in the hallway, and they kind of like grab me. And, you know, we go out and sort of have a discussion, like, do you alert the family, and then do you make a decision maybe to abort with the family's consent, or do you continue with the family's consent? Maybe that helps and at least takes some of the burden of decision-making off, and there's some information that they can make that medical power of attorney sort of driven decision for the patient on the table.
We'll get to you, Dr. Beckes. Thank you. Dr. Link, any comments on that sort of?
We wouldn't, I would say, routinely do that. We have done it when we've gone in expecting a vestibular schwannoma, and it's clearly a facial schwannoma. And then we've gone out and talked to the family and said, you know, here are our options, and this is what we think we should do. But obviously, the family doesn't have much insight into this, so it's rare that we would do that.
Yeah. Dr. Backus, maybe jump in with the,
So just a quickie, I don't know if anyone else has this experience, but in our hospital system, you know, we have a neuromonitoring team that's in-house. And they're part of the operative team. I mean, they point stuff out to us we're not thinking about. They're very, very good. But the hospitals cut costs, and they're now leasing out a lot of the facial nerve and cranial nerve monitoring. So we have to specify exactly what we're doing. And we had a very similar case, and they had somebody monitoring the case that we didn't know, verified SSEPs, facial nerve, ABR. The person left the room. The next person came in and said, you know, we're not monitoring the facial nerve. And I don't know what we were hearing, but they didn't have the facial nerve monitor in the room. And then the original person came back and said, well, I'm really a spine monitoring guy. I don't know what I'm doing. And this is 90 minutes into the case of dissecting on the facial nerve. So people always say, make sure your anesthesiologist hasn't paralyzed the nerve. Make sure the monitoring team knows what they're doing, particularly if they're not, you know, within it. Has anybody else had that experience? Because it was pretty mind-blowing, actually, when it happened.
Yeah, I love when they say that the ABR was gone like an hour ago. You know, that's my
yeah,
favorite.
yeah, right.
That's my favorite, like,
That's-
surprise, you know. But for the trainees also, if it's a trans lab, as soon as you get to any part of the intratemporal facial nerve, tympanic segment or in the mastoid segment or whatever, stimulate as soon as you can, because you immediately know that the monitoring's working. Because there have been times where it's not working, or very rare situations where you have an extratemporal facial nerve paresis for something, you know,
Yeah.
local anesthesia, cautery, whatever. So just stimulate it, and then you immediately know that you're good.
Yeah, we've had a case where the distal nerve in a retrosigmoid, proximal distal, didn't stimulate from the get-go. We hadn't done any dissection. And we sort of switched out everything and still didn't stimulate. So I actually ended up exploring, and in the mastoid, as the bone wax had been used, it sort of fractured the tip of the mastoid in the very beginning of the case when our neurosurgery colleague was putting in bone wax, and fractured mastoid tip and actually caused edema there. And we actually decompressed the nerve, and then it did stimulate, and we could proceed with the surgery.
Yeah, lots of things that can go wrong. It's obviously, just because we have this slide up there, could you summarize maybe in a quick minute?
Yeah, so
just
I mean, you know, I put there that the lawsuit went on for 8 years. I mean, so it's 8 years of torture for both surgeons, you know, all because of, you know, this possibly could have been avoided had there been a little bit of overlap between the two surgeons where things could have been discussed, because there was a very brief phone discussion between the two. There's obviously disagreement between sort of what was said on that phone call. The neurotologist settled, and the neurosurgeon went to court and won.
Okay. This case we're not going to go over. This is actually Cy's case, but I just had to put it out there because over the years in the William House Study Group, we've seen a lot of pictures, many impressive, but gosh, this wins the day for impressive photos. Yes, this is a patient of his who, very medically complex, had been using the CI in this way for some time. Yes, I see a lot of people taking photos of this slide, indeed. So yes, he actually was going to go over this case, and this is sort of I think we'll skip over it to the skull-based ones, but I thought it was worth mentioning. He did, I think the most important one here is with some hope and prayers, which we all would, you know, covering something like this up, that's the key there. Okay, we're just going to actually move through this for a second to go to the skull-based cases. Okay, all right, Dr. Patel, so this is a 10-year-old female with hoarseness. Let's see if we can get this normal hearing by that audiogram down there, right? True vocal cord immobility, has cranial 5, 7 normal, 10, 11 palsy, probably 9 as well. So this is a 10-year-old. This is a challenge. So counseling the family about next steps. Who wants to start on this one? Okay, don't all speak at once. Let's don't all speak at once. Dr. Stevens, have you any? I can go back to this one. So, sort of, how are you starting to think about this case? What kind of things are you talking to the family about?
So I think the first thing you need to take into account is just her age. I mean,
Yeah.
this is a bad tumor. It's doing some bad things. There's a very good chance you're probably not going to cure this tumor. So we're looking at potential future treatments. We're going to be looking at probably some cranial nerve rehabilitation, possibly surgically. So you need to kind of be thinking almost in it like a systems-based approach, kind of almost marching down the cranial nerves one by one. You probably need to be looking at surgery in this person, depending on, the end tissue diagnosis, because that actually could be a couple things, that tumor, that may dictate, some of the things that happen later. And I think you need to get that family ready that this is not going to be just one definitive treatment and then you're done.
Absolutely, yeah. Dr. Link, any comments on that, or maybe how you all would do approach it, even single, multi-stage, et cetera?
Yeah, that's obviously a terrible problem. I think it's a meningioma, and obviously it has intracranial and extracranial extension. I will say that I've surmised over the years that initially I would be very glad that the lower cranial nerves are out, because I would say, oh, we can't hurt the patient in terms of their voice and swallowing, but they're always worse. So I think a paralyzed vocal cord is only one aspect of what the vagus nerve does for voice and swallowing. So I would prepare them for that. There's a chance that she might need a peg for a while, but will undoubtedly learn to swallow again. I think you have to talk to them that this is probably some syndromic problem. And, there may be more coming down the road. I think the hearing is at great risk, but I think she does need a posterior fossa operation to decompress her brainstem, get a histologic diagnosis. Now that we can do molecular characterization of meningiomas, I'd bet the farm this is not a true grade 1 meningioma. And so I think, as listed here, step 1, we would just do a retrosigmoid resection. I don't think we would try and do a big operation where we're going to try and take out the extracranial and intracranial part at the same time.
Dr. Patel, this is your case, I think. What
Yeah.
can you let us know?
Yeah, exactly right. It was a meningioma. Interestingly, grade 1, just purely grade, but I think some of those extra tests and factors were slightly elevated or concerning for a more aggressive thing. On the pre-op scan, there's a tiny kind of triangular-shaped fundal tumor that is also a meningioma, we think, and she has NF2, new diagnosis. And so we did exactly what Dr. Link said, took it out, retrosigmoid. That was a long operation, and then let her recover from that. And then went after the neck. She had a fair amount of intraosseous meningioma that I was able to take out, and then the neck, we did have to leave some tumor on the carotid and the 12th nerve, which was functioning and continues to function. Exactly as Dr. Link said, she did have a weaker voice afterwards. She's gotten some laryngeal rehabilitation since then. But the most amazing part about this case was she's 10, and about 10 weeks after surgery, she was back to doing handstands. It's just amazing how young people can recover. Unfortunately, she did get her spinal MRIs and has several spinal tumors, but all small at this point in time.
Yeah. Well, we're going to go on with an NF2 case, which I think highlights just that case, and also, even some more complexity for either side. So 27-year-old female has a recent NF2 diagnosis, but father is affected with NF2. This 27-year-old female wants to start a family, cranial nerves neurologically intact. You can see the audiograms right and left up there. And then this is a series of scans over the first one, then 6 months later, then, roughly a year later after that, seeing obviously one tumor on this side and then on this side as well. Okay. Father actually has an ABI, so this is a pretty knowledgeable family, growing residual tumor. So patient has an anticipated pregnancy and opted for intentional subtotal. So I thought we could also just sort of start thinking about this case in general. Lots and lots of options here. Essentially no cranial nerve neuropathies with normal audio. These are the scans. Dr. Link, how would you sort of start to think about this 27-year-old woman who wants a anticipating pregnancy, maybe also thinking about some intracranial increase in pressure during delivery, et cetera?
Based on the volume of tumor, I wouldn't be worried about, we get that question a lot in neurosurgery, can the patient go through normal labor and delivery? And almost always the answer is yes. That wouldn't concern me. One of the things is, are we going to see accelerated tumor growth, however, during pregnancy? We certainly see it in meningiomas and with some schwannomas. So I think treatment before pregnancy is a good idea. And obviously, this falls into, I think, a pretty aggressively growing tumor in just a short interval. So we would absolutely have the discussion about either doing surgery, which is a difficult discussion because she's got perfect hearing.
Yeah.
But obviously to try and save hearing, preserve an eighth nerve, or radiosurgery, which of course always preserves an eighth nerve. But I would be worried, I would counsel this patient. I think the chance that we're going to get tumor control with radiosurgery would be in the 70 or 80% range, not the 90% like we would get with a sporadic tumor.
Right. Dr. Djalilian, or anyone have any other comments?
Yeah, I mean, I guess I'm not sure. I mean, I've seen the same thing where these can grow very rapidly during pregnancy, and so I don't know. I mean, I would definitely try to consider doing something before. I'm not sure if subtotal, depending on how subtotal, I guess it would solve the problem, because this is going to grow back unless something else is done for it. I am actually curious what everyone's experience is on Gamma Knife for these patients. We had a neurosurgeon in our children's hospital who is now retired, but he was sort of the gatekeeper for all the NF2s who would come through, and he Gamma Knife all of them. He never operated on any of these, and I must say we never saw any malignancies, even though the literature suggests that the malignancy level is high. I'm curious what people's thoughts are on Gamma Knife.
Yeah, we would not hesitate, really. It's been our experience as well that there has to be some theoretical risk of secondary malignancy, but it comes back to, well, what are you going to do? There's a risk that she'll get a DVT and PE and die after an operation too. It's that level of risk. So it doesn't sway us very much. And honestly, our hearing rehabilitation options, or our results after Gamma Knife followed by CI, have been so encouraging. We were very enthusiastic to do ABIs, but we've only had a couple patients have what we consider to be good results, and the rest of them kind of use it, but just as kind of that sound awareness. So probably we would steer towards that. Of course, it's hard to do a subtotal resection and save the hearing too.
Yeah, it certainly is. It's you try to sort of half the middle, and that's often where all the gray zone is. But I would agree with you. Sort of the CI outcomes in some of these cases have really helped us, because for a long time the ABI and still, CI is far exceeding that even post Gamma Knife. Dr. Patel, I think is this your case?
Yeah.
Yes,
Yeah.
great. Maybe you could take us through this.
Yeah, this was frustrating because right from the beginning, the ABR wasn't great in spite of her absolutely perfect hearing. And I think it was something technical, something with their montage or placement of the probe or whatever. But really, it was just minute by minute, the ABR would continue to degrade, even though we weren't really doing anything that we thought was harmful to the nerve. I did this with Dr. Caldwell, super experienced, and eventually we just got to the point where, because the ABR was non-repeating, we had to stop, even though we felt like we could very easily have gone on further and given her a more legitimate subtotal. This is, like a big biopsy is basically what we did, which is frustrating. But nevertheless, she did fantastic afterward, because we didn't even have to touch any of the nerves, and her hearing's pretty decent after that. And so really it was just mowing the lawn and buying time for her to have a pregnancy, but of course not a definitive solution.
Yeah. All right, thanks for that commentary. Yeah, that sort of case encapsulates the whole thing. When to stop, how to trust your monitoring, what to pregnancy, NF2. I mean, got it all there. All right, so this is a case from Minnesota, so you can guess whose case it is on the panel there. Has diabetes and a flutter on an anticoagulant, has a BRCA mutation, 7-month history of progressive imbalance without true vertigo, then 1-month history of essentially what is SSD right here in the left ear. And the initial imaging 2011, and then this imaging 2020. A year we all remember for things way beyond this. All right, very good. So let's start just in comparison. Let's keep this image in mind, 2011, 2020. 2020. So is this a fast-growing vestibular schwannoma? How would the panelists sort of think of this? Anyone want to take this one?
Yeah, I would say it is.
Yeah.
Just using long division, it would be
Yeah.
25 millimeters over 9 years, I guess. And
Okay.
so it's maybe a little on the borderline, but
Yeah.
I think 2.5 millimeters a year would be kind of the line.
Is that Dr. Djalilian, Stevens? Is this sort of what you would think as well? How are your
Sure. I
long
mean,
division skills?
in general, the larger they are, the faster they will grow, just because, it's only a certain percentage of the cells that are actually growing, and the more cells you have into that sort of marginal difference, of course, varies based on how the tumor actually grows. So when it's in the IAC, it's all linear, but then it's going to be volumetric in the CPA. So yeah, obviously this is a fast-growing tumor. I don't know if I could put a number on it, unless I have another MRI in the middle.
Dr. Link, do you want to take us through some of the surgery here?
Yeah, so I think it's a hard question to answer also because she got an MRI in 2011 because of her cancer history. She was getting screened for metastases, and it was absolutely negative. And then 9 years later, she has this 2.5 centimeter tumor. She had some comorbidities, but I was worried it was a faster growing tumor. So we elected to operate on her. We did that translab. And after Colin got done drilling, he said, the whole superior aspect of this tumor in the IAC stimulates, so be careful there. And then I opened the dura and looked around, and the entire superior aspect of the tumor stimulated, and it was soft and hypervascular. And, we worked back and forth and ultimately said we're going to have to leave some tumor. And as Colin noted yesterday, despite doing a subtotal resection, we had a bad facial nerve outcome. You can go to the next slide.
Yeah.
So immediately postoperatively, she was a grade 6. By 3 months, she'd recovered to kind of grade 3, 4. And I noticed, Tessa never, and all the facial nerve reanimation people, they don't use the House-Brackman scale because it's just not very good. But, so she had movement in all divisions. She could get fairly good eye closure. Her blink was asymmetric, and her left eye didn't close with just spontaneous blink. So at 3 months, this is what our MRI looked like, kind of as we expected, where that superior corner, we had to leave tumor. And then we followed her for a couple of years, and it really didn't change. But then all of a sudden it did.
Yeah.
So over just a little over a year, it went from being stable for 2 years to being pretty large again.
Probably we don't need the pointer here.
Yeah.
I mean, the appearance is definitely not one of a metastasis, but would you have done an LP beforehand to check, given her previous cancers?
No, we didn't even consider it, to be honest.
Why wouldn't you do Gamma Knife in someone who's this medically complicated to begin with?
Wow.
To begin with, I mean, to begin with, I mean, I think, The volume was one issue, the fast growth was another issue. And she had some comorbidities, but not terrible. She was only in her 60s.
I
So,
mean, just the warfarin and all that, so that's why I was wondering. It just makes it a little more
Yeah.
complex around the time of your surgery. I mean, obviously, it doesn't work as well. I mean, your guys' paper said, but it's about 77% still, I think, if I remember the numbers correctly, that there still is good control with that.
so yeah, so, what to do with this recurrence? And the question is, would anybody reoperate again? Or, she's House Brackman 3-ish, 3.5,
How old is she at that point?
67.
Yeah. And did you think about gamma knifing her, a year out from surgery or less after the facial nerve function stabilized?
Not really. It wasn't a great target, honestly. It was pretty small, and it was kind of linear out the IAC, and I thought, we'll just keep watching her. I think there is a risk of aggravating her facial function if you gamma knife, even if it's been stable for a year, for instance. So I really didn't.
I think this is one we would probably go back and operate on again, just to debulk it, get a little bit of that volume out of there. Your target becomes smaller. Friend here. And then the other thing is, by that point, years have gone by, I think, now from the original surgery. So the patient has had a little time to maybe emotionally cope with that facial palsy. You have a little bit more time to prepare them. This is a reoperation. We may have to do radiation now to control a regrowth. They may be more ready, I think, for that outcome if we ultimately end up losing facial nerve function.
And she did very well, I'll say, with her facial weakness. I mean, she was okay with it, I'll say. But obviously our decision was we treated her with gamma knife. Use standard dose and sort of nothing remarkable about that. And then this is where we are now. She's had progressive imbalance. In fact, she had a fall with a clavicle fracture. And, her tumor's enlarged about 3 millimeters since I treated her. And so the question is, should we just continue to observe her? Should we repeat gamma knife? Should we try some other type of radiation? Should we, reoperate now? And trying to save her facial nerve? Should we reoperate and say, look, we're just going to take this out and be done and blitz your facial nerve, and then we're going to do some of those things Tessa talked about to reanimate her face? Or should we just retire?
Well, that's a great segue, I think, to Dr. Driscoll's the next. I just wanted to really thank the panelists so much for both sharing your cases and your complications. Thank you so much for everyone's great discussion. I'm going to turn it over to our retiring ANS president. Thank you so much, everyone.